Dottoressa, magari può chiedere al dottore. Un'informazione serviva a me.
It's a long walk. It's a long walk to freedom. Yeah. With many corners.
Okay, I think you can hear me. Thanks. Okay, I think that we can start. First of all, I would like to say good morning, but also good afternoon and good evening to people who are joining our virtual meeting far from virtually far from Rome. My name is Stefania Burbo, and this year I'm one of the coordinators of the Global Health Working Group together with Robin Montgomery. Thank you all to attend the Health Equity Parallel Session. This is an event organized by the Civil 7 Global Health Working Group, which Robin and I would like to thank not only for the tremendous effort in organizing this event, but also for preparing the recommendations for the G7 that are included in the Civil 7 communiqué. I'm very proud to say that this is a group of people from all over the world strongly committed to putting health back at the center of the political agenda. There is indeed a lack of progress on health equity and health justice towards the 2030 agenda. So the objective of this session is to discuss health equity as a central pillar to access to healthcare, while showing the importance of meaningful community participation in decision-making processes, as they are the linchpin to UHC and effective pandemic PPR. The G7 has repeatedly reaffirmed its commitment to strengthening global health systems based on the principle of leaving no one behind that all we know. So we want to draw today the attention to the need for a tangible commitment by the G7 to address current gaps and ensure the right to health for all. That means without discrimination, without criminalization. Now, a few words regarding the format of the session. It is intended to be a dynamic conversation. So there will be a first round of questions posed by the moderators to each panelist, followed by a second round, then a Q&A session and closing remarks by Robin. I would like to say a few words of thanks. Thanks to all the panelists and the moderators. Thanks to FAO for their hospitality and for providing us with technical equipment to set up a hybrid event. And I would like also to thank our colleague, Elisa Bernelli, who you can't see her because he is right now assisting us for a smooth remote process. And thank you also for her tireless work to support the Global Health Working Group coordination. Now, I give the floor to our moderators. They are Peter Wiesner of Action Against AIDS Germany and Ben Phillips of UNAIDS. Thank you very much.
Yeah, thanks so much to you, Stefania. I'm really honored to be here and to moderate this discussion together with Ben. Allow me to start the session with some personal comments. I'm now 11 years living with HIV treatment. I have a wonderful doctor. I'm a gay man. He is a gay man like me, and I can discuss anything with him, anything personal or related to treatment that I get. 11 years, that means the statistics tell us, would I be without HIV treatment, I would not be among you anymore. So the treatment gives me the chance, the ability to be still alive. I'm in a very lucky position, coming from a rich country. The country is Germany. You might have noticed it from my accent. According to UNAIDS data, globally 9.2 million people are still not having access to treatment. And there's one person dying on HIV-related causes and diseases each minute. So let's keep that in mind when we talk about health equity. So health equity for me means that every person on Earth in need for treatment has access to it, has access like me. This should not depend on the place a person is born in or depending on a country, if the country is rich, privileged, or not. To have access and to ensure access is not a personal issue, it's a political choice. And I count on the G7 heads of states to make that reality. Health is a human right, make it a reality. So with this personal words, I would like to start that first sessions. Our speakers in this first round will share their reflections, their lessons learned, and insights on how we can achieve the health-related SDGs and ensure health and well-being for all at all ages. And we will ask each speaker to introduce themselves when they start talking. You will find their complete bios on the C7 web page, so feel encouraged to have a closer look. We force our speakers to be strictly within the time limit of 4 to 5 minutes. So we will become the bad cops if this gets longer than 5 minutes. We do this not because we are evil or mean. We do that because we want to have a discussion afterwards. So please stick within the time frame. Otherwise, we will pull out the stick. And you will understand that. So thanks so much for applying to that. And now I ask Carmen Ryan. So Carmen, please introduce yourself. And the question to you is, based on your experience, Carmen, which are the key challenges to ensure meaningful participation of women and girls in all of their diversity and affected communities more generally in health policymaking processes? Could you please share briefly some top of mind best practices? And please don't forget to introduce yourself. Thank you.
Thank you, Peter. Thank you, all of you, for the time. And thank you, Stefania, Beatrice, and Robin for the invitation. So introductions and content in 4 to 5 minutes. My name is Carmen Ryan. I'm the advocacy lead and the institutional director of Fundación Huésped. Fundación Huésped is an organization based in Buenos Aires that has been working for HIV, health and reproductive rights since 1985. Our first approach was based on tackling the issues that combined health, stigma, and discrimination. And it started with HIV and then grew on with other health issues that included the need of this open, people-centered approach. So when you tell me what the challenges I think there are on social participation, I think they are mostly among the people that has to plan for those social participation scenarios, those social participation policies. Public officials, decision makers usually believe that social participation is complicated, time-consuming, and expensive. And maybe they are right, but they are also worth it and necessary. Why do I think they are worth it and necessary and also complicated? They are complicated because we need to reach out for the farther communities, the ones that we need to get to the health services. For those among us working on HIV, it's easy to think about key populations. And when we think about key population and we think about reaching people incarcerated, sex workers, LGBT community, transgender community, then we think they are not usually reaching out, knocking on the door to the health system saying, oh, I need PrEP. This is not the usual situation. They usually don't know what services they could be getting, and they usually are not reaching to the health services because they're finding discrimination, barriers, criminalization. So we need to have spaces where we can talk to them, where we can educate the community on the scientific-based information we have, but also educate us, civil society and decision makers, on how to dialogue with this community, understand not only their health needs, but also their daily lives, their cosmovision on these topics. So we can understand also the power dynamics that go between them and the health system, and also within the communities. So when we think about some better examples, I have only 2 minutes left, some better examples of how to gain this participation. We think there are many different ways, many ranges of participation. You can make a pool, you can have a committee, you can have peer navigators. There are different intensities of participation, and in each of every one of those, you're gonna need interdisciplinarity, approach, and a committed decision to hear what the community is saying. So it's probably gonna be a little complicated. It's going to be time consuming because there's no check marks when it comes to social participation. It's not like done it. Community has participated. They need to participate on the planning, on the implementation, on the evaluation, and you're going to have to keep listening to them all over the process. And also, they actually expect accountability and it's not going to work if you don't have accountability. If people participate, but what they say has no meaningful impact in the policy you're going to implement, then the participation is not going to work. And also, this all takes time, takes people working for it, so it takes money. But it's much more expensive, it's much more complicated, and it's much more time-consuming to develop health policies that don't reach the community they are intended for. Because if you're not going to reach the right communities with the preventive services, then you're going to have not used for cost-effective intervention. You're not going to have just justice, as we are saying. You're going to have more complex intervention, more expensive services, and more time-consuming complex medical services. And you're going to miss out on many opportunities to reach out the branch communities. And also, you're not going to have the good impact in a community that is going to build better connections, better capacities to work among one another. So I don't know if I have answered your question, but I tried.
Thank you so much. Almost done, but beautifully you mentioned all the points, and thanks for coming. You said about accountability. We discussed about accountability frameworks. I hope we hear more about that later in the session. So I hand over now to my co-moderator, Ben.
Thank you. Thanks so much, Peter. I have a question for Satyam Isur. So Satyam, can you tell us, based on your experience, how can the participation of young people in health policy making processes improve health equity? What are the key principles of youth engagement?
Thank you so much, Ben. So I'm Satyam and I'm from Mauritius, and you must imagine that this room is super cold for me coming from a tropical island. So yeah, just coming back to the question, Ben. So, I mean, we have to agree that the world that we're living in today, we have the knowledge and so we have the knowledge and resources and even the capacity required to deliver on the 2030 Sustainable Development Agenda. But 9 years after the adoption of that agenda by the UN, by all UN members, we cannot shy away and not say that we still have a long way to go. And this is especially true when it comes to global health. And we see that there's a significant gap. And that gap is especially, we see that within the African context, and it impacts individual health outcomes at so many different levels. And here I really wish to draw a parallel between the MDGs, which saw a significant setback as it failed to see linkages between health, poverty, gender inequality, climate justice, and other health-related areas. But above all, I wish to say that it failed to recognize the importance of involving communities and especially young people in the process of implementation to achieve those goals. So I guess what I'm trying to say is that the MDGs overlook the importance of involving young people in the development processes. And the good thing is that today we do recognize that this was a mistake that we did, and we're trying to involve more young people in decision making. But we need to also realize that if we continue on excluding it, it means that we're excluding valuable perspective, experiences, and even contribution that can affect the overall success of the implementation of the goals. And today, we know that there are around 2 billion young people, which accounts for nearly 1/4 of the global population. This means that there's 2 billion people that are directly concerned, affected, and impacted by health policies. So it's important to recognize that those 2 billion individuals are at the epicenter of intersecting emerging threats, being pandemics, be it climate change, be it conflicts. So it's important that we recognize that those young people have the transformative power and the potential to bring changes to the world. So to answer the question on how the participation of young people in health policy can improve health equity, I would say that young people should be seen as a positive force, and we should see young people as the drivers of change. I wish to again draw the parallel to the work that I've been doing in Mauritius, and I have for the past 5 years worked with young people at different fronts of HIV response in Mauritius. And I can tell you that young people really do bring a unique perspective when it comes to implementation, because they have all these creative ideas that you would not be thinking of. And they are like, they know how to use technology, they know how to use new tools, which it's really interesting to see that they bring in new ideas, which we will shy away when we hear them first. But now we need to say, that, okay, we're listening to those ideas and we want to help you implement them. So I think we should also not forget also that we involving young people in decision-making regarding their health, we are also laying the groundwork for the future generation that is coming. And this is an important aspect that we should not overlook. And to go back to the SDGs, I think it is really interesting to note that on a global front, we, and hereby we, I mean civil society organization, governmental organization, and other institutions, we already came to that realization that young people should be part of decision-making process. But when it comes to concrete and meaningful participation, this is where we see the stagnation, because we know that young people are participating. Even in this room, we have so many young people here with us, but the stagnation is still happening. So for me, I think that it is evident at many levels where there are mechanisms such as youth parliaments and even youth engagement council, youth advisory board, or any other youth-related initiatives, they struggle to make a concrete and real impact on the decision that's been taken. So this shows that young people, we still have that frustration that we exert little influence over decision-making. We are here and we just don't have that power to influence decision right now. So either this means that the current arrangement around youth involvement is either ineffective, or for me, it is maybe tokenism, where young people are just being given a seat at the table for the appearance of inclusivity and diversity. So in terms of key principles that you asked for youth engagement, I think we need to consider the 3P approach, the 3P being purpose, process, and power dynamics. This is really important. When it comes to purpose, we need to inform young people and educate them about their rights and why they are here with us and what's the meaning behind their involvement. In terms of purpose, I think it has to be, in terms of process, sorry, it has to be in terms of how we can make, create accessible opportunities and resources, including funding and even compensation to young people, so that they can contribute their perspective and ideas effectively. And in terms of power dynamics, we really need to start addressing the unequal power distribution between young people and decision makers. This is when the whole process will really be equitable and our voices will be heard. Thank you.
Thank you so much, Satyan. Thank you. It was both challenging, but also optimistic in the end, I think. I hope. Now, we are lucky we're also joined, but virtually, by Moga Kamal Yani, who many of you will know is a leader on access to medicines. Moga, can you hear me? Yes, great. And I think people can see Moga as well. Brilliant. So Moga, as a global health activist and health advisor, what is your view on the role of communities and civil society in ensuring equitable access to medical technologies?
So first, thank you very much for inviting me, and it's nice to see you all here, although virtually. So yeah, civil society and community have been playing a very important role, as colleagues also mentioned. And HIV activism is particularly, a shining example of the role of both communities and civil society. The movement, I mean, it's become a movement for equity in HIV. It showed the needs, it showed the demands. It's before the activism for HIV treatment, basically health inequality was accepted. Nobody complained about it, it seems, it's fact of life. And we heard it a lot. We have no money to treat people with, millions of dollars for all their life. Or others saying, well, price is very high for medicine, kind of fact of life. But activism destroyed that message, really. And it showed that, you know, we used life stories, we used the evidence, data, media, advocacy campaign, all that to show the whole world that one, there is a need for this medicine, and it's not justifiable to have not to have it, not to deprive people of that and let them die, but also to show that it is possible if you change the system and cut the price. The story repeated with COVID vaccines. It's been repeated on a smaller scale on other diseases, you know, cancer, cystic fibrosis and whatever, but the vaccine inequality actually showed, you know, made us, we had to raise the issue that there is fundamental problem in the system. So that's, you know, raising these issues and challenging the system that produces and distributes and allocates medicine. That's an important role of civil society and communities. At a community level, you can monitor which products is coming to your area, your clinic, or your primary healthcare unit, you know, the time, the price, the expiry date, all these kind of things. Communities can do that if they trained and you know, there's payment for people who deliver that kind of service. I don't believe in free lunch, and I can't see why community workers shouldn't be paid. But the other thing that we do as civil society and communities, we do research, we do analysis, we look at the structural reasons, as I said, in terms of medicine, the lack of R&D for specific diseases that bugs people in certain countries, and particularly Africa. You know, if you remember, Mpox became in the news when it hit Europe and America. But before that, it was just like, you know, DRC, the variant in DRC is more fatal than the one that hit Europe and America. But, you know, people live with it, and that's that. You know, maybe WHO or MSF or others intervene for that particular country, and that's it. But not challenging the fundamental issue about, do we have a vaccine? Do we have a medicine, which we do in Mpox? And where do they go? Who control these medicines? And one of the solutions, if you like, that we're putting forward is investing in local production, or rather regional production, where in terms of Africa, African leaders take the lead and invest in their own local production, but they need technology transfer, and they need to waiver intellectual property, and they need support with financing. But they need to take the lead on that. That's one of the, if you like, solutions or way forward that civil society is putting forward in the pandemic accord that's being currently negotiated, but also in general when we talk about access to medicine. Otherwise, we'll be dependent on what comes from the north, and that's you know, dependent on pharmaceutical companies' charity is not a sustainable way of delivering medicine to your people. So in that, we work with governments, we work with WHO, we work with other institutions, and try to find ways of solving out the problems of access to medicine by looking at all the fundamental value elements in the value chain, from R&D to production to intellectual property, technology, you know, the actual manufacturing, the delivery, the health workers. So all that value chain, we have some ideas of how to sort it out, and based on the experience that are happening in some countries. You know, it doesn't have to be you know, experience in Britain or in France. It experience in Brazil, in Thailand, in Vietnam. You know, countries have experience of delivering health service and delivering access to medicine for their people.
Thank you so much, Moga. Thank you. That's really powerful on the role of civil society, challenging policies that don't work, but also challenging power by building our own collective power. Peter.
Yeah, thanks to the speaker so far for keeping the 5 minutes. We didn't have to pull out our stick that we have with us. You did hear already something about the HIV movement and the importance of and the history of it. I'm super happy to have Linda Mafu with us. And you can talk about this as well, I know, probably better than I can. So Linda, communities living and impacted by AIDS, tuberculosis, and malaria and civil society are key partners for the Global Fund. How does the Global Fund support and advance the involvement of communities and civil society to improve health equity through right-based and gender equitable responses to the 3 diseases? And please don't forget to introduce yourself. Thank you.
Thank you so much, and thank you for such a warm welcome. Thanks to the fellow panelists as well. My name is Linda Mafu, and I'm the head of Political and Civil Society Advocacy Department. That's a long one, at the Global Fund within the external relations. And the role mainly is to make sure that I work with civil society and I work with policymakers in making useful noise around resources for health and resources for HIV, TB, and malaria. That's the basic, it's the drum beating around mobilizing resources. In terms of the Global Fund, I will talk a little bit about the establishment of the Global Fund and the role, therefore, that is played by communities. A reminder that the Global Fund was actually a call by civil society and affected communities. It was a call to the global world to make sure that there is equity and there is accessibility of affordable treatment for everyone. I'm a South African. I come from a country in 2002, just before the establishment of the Global Fund. We wore black every day because 500 people were dying per day as a result of HIV. We were going to funerals from Monday to Monday. And the reason was because we could not afford to buy treatment. And therefore, the Global Fund came about to address that injustice, that inequality. The inequality has been pushed by many things, fueled by many things, including poverty, including the marginalization of many populations. And therefore, communities did not have a choice. They were forced to speak up and to speak out and to fight for their lives. The Global Fund, therefore, is a people's fund. I call it the People's Fund. It is the People's Fund, and we strive to make sure that the communities are always at the table to make the decision. So if you look at the Global Fund's governance level, you will see that there are 3 seats for communities and civil society to engage, to influence policies, to influence the funding model, to influence the accountability mechanism. So we make sure that civil society are there. At country level, again, there's a multi-stakeholder mechanism, which is the country coordinating mechanism. And there again, communities have their place and have their voice. We then also invest as the Global Fund to ensure that it's not just ticking the box that communities are there. We ensure that communities are getting the technical support so that they really are meaningfully engaged. They are really influencing the discussion. Where there are countries where some communities experience criminalization, we find ways of ensuring that they are organizing themselves. We provide technical assistance so that they're able to engage, they're able to speak about the challenges they face, and also ensuring that they are organized and they are supported in a way that they have the evidence, because advocacy is always supported by evidence. So we work with communities around that. And that is very important. Together with communities, civil society, government, and the donor countries, we have managed to invest at least 60 billion US dollars on HIV, TB, and malaria to ensure the access to healthcare services, to ensure the life-saving treatment is provided to people beyond just the people that can afford, but making sure that we reach out populations that you would not be able to afford treatment because it cannot be a situation where I'm unable to live my life because I cannot afford to pay for my treatment. So again, addressing that and working, we have been able to distribute the 60 billion US dollars. And this is a result of the G7 countries that have really supported the Global Fund, the European Commission that have supported it, and many other countries that have contributed, including some of the implementing countries. They have also come to the table to support, and therefore we have been able to manage that. We also have been working on ensuring that we have the youth voices, the key populations also supporting us to ensure that the policies talk to some of the, and I look forward to talking to the young person on the table because we have a youth council and we need to look at how do we make that work.
Thank you so much.
Thank you.
Thank you so much, Linda. The applause is yours. Thanks for referring to what meaningful engagement is at decision-making level. It seems to me to be that you already responded to some of the questions that Satyam raised. So by saying this, we go now to our next speaker. So Sylvia Sanasi, sorry for that. I didn't train it. Good that we have you with here. Our question to you is, the G7 has repeatedly affirmed its commitment to achieving UHC, universal health coverage, as part of the 2030 agenda. Nonetheless, the goal is still very far from realization, hampered by profound inequalities within and among countries, as well as by worrying trends of backlash against human rights that affects both the global North and the global South. What will be this year's G7 contribution to advancing health equality under the Italian presidency? So thanks for responding to that and thanks for being with us.
Thank you, Peter. I'm Silvia Sanasi, medical officer at the Italian Ministry of Health, national focal point for G7, G20 health topics, and this year also G7 coordinator for health technical content. Now, before answering the question, I would like to thank the organizer for the invitation and for the fruitful moment of discussion dedicated to equity and communities' perspective to improve the G7 approach to global health. Let me also express my appreciation for the activities conducted by civil society organizations, especially in the most vulnerable context. Health is a transversal topic, and in particular, the role of civil society whose activity on the field is considered critical in reaching important goals can contribute in a proactive way to convey alternative perspectives in relation to global strategic issues, especially in these difficult times. As we speak, several humanitarian crises due to ongoing conflicts and global health challenges like the COVID-19 pandemic continue to cause losses of human lives, very high social and economic costs, a constant sense of insecurity, and contribute to exacerbate inequities, especially in low and middle income countries. Tackling health inequalities in the current international scenario gets more complex every day and needs to be urgently addressed. This is a compelling issue also to prepare to future pandemics and regain lost ground on the health targets of the 2030 agenda. As a G7 presidency, Italy this year has built its program on the foundation laid by previous G7 and G20 presidency on major topics that are considered critical for the global health agenda. Italy in particular is one of the promoters of the Global Fund and the Pandemic Fund hosted by World Bank, and together with the rest of G7 membership among the main public contributors of a financial initiative on global health cooperation. This year as well, we aim to maximize the synergies with all the international initiatives and network competent in health matters that can actively contribute to achieving our G7 health priorities, which can be described in 3 pillars. The first pillar is focused on strengthening global health architecture to guarantee universal and equitable access to quality healthcare, also to the most vulnerable population, with the aim to fight inequalities and leave no one behind. On these issues, as G7 membership, we call for continued support to the pandemic fund, including expanding the donor base in view of its next replenishment round, as well as expanding sustainable MCM's development manufacturing and last mile delivery, including the Gavin African Vaccine Manufacturing Accelerator. And we also support the initiative described during these morning sessions by my colleagues. For a strong global health architecture, it is also critical advancing in universal health coverage and investing in resilient health systems, primary healthcare service delivery, and the skilled health workforce, including through the WHO Academy, the G20 Public Health Workforce Laboratorium, and the UHC Knowledge Hub. The second pillar is focused on lifelong prevention for healthy and active aging, and I will provide more details on this topic later during the discussion. While our third pillar is focused on the One Health approach that encompasses also the fight against antimicrobial resistance and climate change, two phenomena that affects all countries and whose negative consequences are mostly experienced by LMICs, where the provision of health services is particularly difficult. The One Health approach, with its One Health Joint Plan of Action developed by the quadripartite, incorporates the benefits of the integration of environmental protection and health prevention policy, strongly promoted by the Italian Ministry of Health. To tackle climate-related emergency based on the discussion of COP28, we are promoting multidisciplinary strategy and transparently a share of good practices to reduce climate change-related mortality and implement action. On IMR, as G7 countries, we are promoting prudent and responsible use of antibiotics in both the human and veterinary fields, sharing good practices on antimicrobial prescription and supporting both access to existing antimicrobials and research aimed at developing new molecules. Also in view of the upcoming UNGAIG level meeting this year dedicated to IMR. In conclusion, the G7, led by our presidency, commits itself to the international front to supporting peace, democracy, and the protection of human rights. First and foremost, the right to health and access to health services, especially in this historical moment characterized by multiple conflicts in which the most vulnerable groups pay a very high price in terms of physical and mental well-being. Thank you.
Applause. Thank you so much. And yeah, thank you for providing us an overview on what the main issues are. I hand it over now to my co-moderator, Ben.
Thank you. So in this second round, we're going to be really focusing down on what do the panelists and all of us want the Italian presidency of the G7 to take forward. What is it that we're asking those in power to do? I'm going to start with Carmen. So Carmen, with sexual and reproductive health and rights, which are essential in health policy, what, in your view, is needed next to ensure equitable access? And how can the leadership of the G7 meaningfully accelerate that?
Thank you. Well, it's a difficult question. When we think about sexual health and rights, we are thinking about supplies and services that will produce the possibility of women to live a life of freedom, to enjoy a life of freedom, to access a job, to take decisions on when and if they want to have children or not. And we are also going to have preventive services for the whole community and services for transgender communities. It's an agenda that is key for us. It's key for the communities to access to their rights. So the first thing we need, I'm going to take Linda's words, is to keep an useful noise, for the topic to stay in agenda. We need that sexual health, sexual reproductive health and rights are no silenced from the global health agenda. If we stop speaking about it, then all the other countries are gonna understand that there's that possibility, and we cannot afford that to happen. Every time we stop speaking about sexual health, there are children, kids, girls, boys that are not getting sexual comprehensive education, that are not getting the supplies to access to protect their health, to ensure the ownership around their body. So the first thing should be to keep the voice up. The second one would be to ensure participation. We cannot enforce this kind of policy without proper participation, meaningful participation of the communities. The third thing I would like to say is to commit with the finalization of the practices that criminalize and discriminate communities. Health services can't be a place where people fear to go. The decision to access to health services cannot be contraposed with the freedom. So criminalization of abortion, criminalization of HIV exposure are situations that expose communities to serious decisions. So the G7 could take a point stopping criminalization, and with that moving forward with stopping discrimination. Well, that kind of, I think that's a lot to ask. So I'm gonna set the word for the other participants.
Thank you. Thank you.
So thanks so much. You saved us 2 minutes, but it doesn't mean that the others can speak longer, because we want to have a discussion afterwards. So I go back now to Satyam, and the question to you is, one of the recommendations of the C7 to the G7 is of our recommendations, right? Is to support the elimination of all forms of discrimination and criminalization from health policy frameworks at all levels. In your opinion, what are the key policy changes that G7 leaders should push for this year at the Italian G7 summit? Thanks, Satyam.
Thank you so much, Peter. Before we dive into key policy changes, I think it's really important to go back to fundamental principles of the SDGs. I mean, this fundamental principle was even endorsed by member states, and that principle is to leave no one behind. So the principle signifies a huge commitment from UN members, where they have to ensure that all individuals, regardless of their backgrounds and circumstances, and I stress on circumstances, have equal access to healthcare. This means that countries have to imperatively work towards reduction of discrimination, inequalities, vulnerabilities, and all those things that's leaving people behind currently. And we still see that as of 2024. And despite this commitment, I mean, it was really interesting to see the UNAIDS 2022 report that talked about how 134 countries still had laws that criminalize people for HIV transmission, non-disclosure, and exposure. 134 countries, 153 countries policed or criminalized those who work or use the services or benefited from sex work. 70 countries criminalize same-sex relations, while 20 countries criminalize transgender people, with the situation worsening with few countries, and we're seeing that right now in 2024. 115 countries are still criminalizing drug use for personal consumption. So these punitive laws, they have shown us their ineffectiveness. And when it comes to health, especially within the HIV response, countries that have laws that criminalize or discriminate against individuals based on their practices or circumstances, they see a public health burden when it comes to HIV, HCV, TB, or even other sexually transmitted diseases. And in contrast, we've seen that countries have greater gain when they have laws that advance human rights, or they have advanced human rights protection. So we need to realize that at the end, the discrimination and criminalization of particular health-related behaviors only contributes to more spread of infection and viruses. So it's more that we need to look how there's a chain of circumstance that happens or keep on happening when we criminalize people belonging from communities, or when we criminalize people because of their illnesses, and we criminalize people because of their health-related behaviors. So firstly, when individuals from marginalized communities like the LGBTQIA+ community, drug users, sex workers, or people living with HIV are criminalized and incarcerated, it often leads to a disruption of income and access to the basic services that they had before being incarcerated. And secondly, being in prison can subject these people to physical and even mental trauma. And this often leads to a reluctance to go back to care. And all these things that I'm saying today, it's not my word, it's things that have been documented, and we have evidence for all these things. And even in one situation that I can talk about in Mauritius, we have the character certificate. Once you are incarcerated, you get that certificate and you have to present that to get a job. So if you have that on your certificate, you're not able to get a job and you're not able to go back to a proper life or rebuild your life. So at the end of the day, what we're doing is that we are double punishing, triple punishing people and keep on pushing them down. So for me, the obvious step for the G7 leaders, it can be to promote constructive alternatives to criminalization and to simply push for the stopping of those laws that target or have a negative impact upon communities and health-related behaviors. So, I mean, when we talk about leaving no one behind, it's the fundamental principle that I think the G7 leaders should go back to and ensure that steps are being taken to identify and address discrimination against communities. And I would also secondly urge the G7 to promote inclusive governance and structures that empowers marginalized communities to ensure that their voices are heard. And here, when I talk about inclusive governance, it should be transparent, and we should have accountable systems that prioritize the needs and human rights of all citizens. Thank you so much, Peter.
Thank you so much for referring to the UNAIDS 2022 report and mentioning the laws and the number of laws that are exactly producing what we are talking about. I would add here, I mean, and referring to the key populations, of course, which is in the center of the approach of UNAIDS and the Global Fund as well. I would as well mention here the impact of community-led monitoring, because all the data we have sort of relates and refers to community that would report that. So I worked in prison for quite a while for an NGO, and I understood that the data the bigger organizations do get from the government are not the real data. So there's a lot of, you can say, lying around that. So we are among ourselves. I just said it, but yeah, you know, community-led monitoring is extremely important. Probably we talk about it later, or maybe there might be a response or a question from the audience. So I hand over to my colleague now.
Great. And Moga, we're back to you. And we're keen to hear from you. And it's on community-led monitoring and community-based monitoring. How can that help strengthen transparency and mutual accountability? And how might it help strengthen accountability for some of the things that might be being pledged at the G7?
Well, I mean, community working with NGOs, so collectively civil society is the one that really monitors what happens exactly on the ground, rather than the nice glossy brochures and things about achieving this and achieving that. And just to give an example, you know, years ago I was working in Oxfam, and we campaigned for and lobbied really hard for debt relief. And in one country in Africa, what happened was we set up a system. So as civil society, working with local civil society and local academia, our national rather, academia, we set up a system where people in certain villages would have like their own committee to monitor how much money is getting to them. The idea was debt was relieved, but the money would be used for health and education. So they were monitored if the teacher got paid, if the school building got improved, if, you know, they had their own criteria for improvement, and they were monitoring that and and when with the NGO feeding that back to policymakers in the capital. So that example stick to my mind all the time, that it is possible, and it's really useful and truthful to monitor. Now, add to that what colleague said earlier about involving young people and technology. With your mobile phone, you can monitor lots of things that happen at the community level. So if the G7 promised, I don't know what they will promise. If they promise more money for health, we hope. Then the civil society will work around, okay, so how much country X is getting from this money, where the money is being spent, and then down to the villages and the other communities, whether it's people in prison or people in a shanty town or people anywhere that you can call community, or they can call themselves community. They can monitor what changes are happening in their life as a result of this money or this whatever it is that they producing. The other issue that we need to monitor is the lack of commitment from global leaders. So, for example, right now, there is this negotiations in Geneva on the pandemic treaty and the amendment of the international health regulations. If there isn't commitment, serious or binding obligations on sharing technology, for example, then these communities will not have access to medicines or vaccines or other things during pandemics. So, do we wait until there is a pandemic, then people say, oh, we don't have a vaccine like COVID vaccine, when people just gave up on the vaccine at the end? They waited and then got some donations of expired vaccines, so they just gave up on it. So I think it's monitoring their rights to know what's happening in their country, and also monitoring what happens and what doesn't happen, what should happen but doesn't happen, and how that affects their own life. And it doesn't have to be pandemics. There's outbreaks everywhere, particularly in Africa. So people can monitor what outbreaks they have, what response happened to this outbreak, compare it to the response that happened last time, compare it to the response next door community or something. So what you're getting and what you're not getting and what's available for you. So that's where civil society role is important, in working with communities to understand what can be available for them but isn't, and why. And therefore they can demand what they can have, like whether it's vaccine or medicine or condoms or goodness knows any other product that they should have. For health workers to demand protective equipment, and there's no moral or justifiable reasons that health workers should be exposed to infection because of their jobs. So this kind of work around community leadership, community monitoring of policies and of programs is absolutely critical. And the world is changing. And if world leaders don't understand that the world is changing, that this little technology is now young children can play with mobile. You don't need wires and systems and whatever. And they can actually report on things and say things and do things. And just one thing, is not just the technology in terms of, you ask a child how to do that in a mobile telephone. It actually creates creativity. It enhances the young people's creativity, and that should be really used as an asset for community monitoring of policies.
Thank you so much, Mogo. Thank you. And you pointed out so powerfully how the role of communities is from the ground up all the way to international processes too, and how the G7's responsibilities are not just about aid programs, but also their international policies, for example, on the pandemic accord. And I think we've only got a couple of weeks left, right, before leaders decide whether the next pandemic should be in a better run than the one we've just had. Let's hope they decide it would be nice for us to be healthy next time. Peter.
Now we get over to Linda again. So Linda, the question to you is, the human rights approach underpins the programs supported by the Global Fund. How can compliance with this approach be ensured in Global Fund programs implemented in less human rights sensitive countries? And I'm sure you know what I mean when I talk about less sensitive human rights countries. So please be precise and feel encouraged to mention the countries as well. Thank you.
Damn. What a corner. Thank you. Thank you so much, Peter. So if we just look at the Global Fund strategy for 2023-2028, we have put health as a human right. It's quite important in that way. It is about making sure that it is about that's not me. It is about making sure that people are able to access services. I think, as you have mentioned, Peter, that there are countries that there has been an onslaught of many countries that are looking at criminalizing populations, pushing populations to corners where they are unable to access services or even come to the table to talk about some of the challenges that they face at their community level. So there are a couple of things and mechanisms that the Global Fund have put together. First of all, we work with communities, we work with the affected communities to direct the response of the Global Fund, to influence what the Global Fund needs to do, particularly in the countries that have criminalizing laws, so that we ensure that we do no harm, we provide the safety that is needed, but also we leverage the Global Fund's diplomatic voice to advocate for change. We have a code of conduct that is followed up by the OIG, the Office of the Inspector General, that looks at how the implementation of programs, particularly supported by the Global Fund, how are they implemented, how do they ensure human rights are respected. So there's that mechanism. We have also worked with about 20 countries so far in looking at breaking down the barriers, and we are using an initiative that is supporting countries to respond to some of the gender inequities, human rights violations, and supporting those countries to respond to that so that we can then achieve some of the key results and targets that we have set around HIV, TB, and malaria. Through that, we've started the Breaking Down the Barriers initiative in 2017, and now we are at a level where more countries are coming in. We've just, in this grant cycle, added 4 more countries, and therefore there's a need, and we have increased the resources around that to support. We are also working closely with countries and also with partners to ensure that there is mitigation of risk and identifying countries like Uganda, like Ghana, to see what are the risks that are faced by key populations in those countries, and therefore what do we need to put in place to support them, what kind of legal process is needed, what kind of safety measures are needed. We also work with the health administrators to look at reprogramming and ensuring that there is continuation of services for key population. It's a struggle, it's a long walk to freedom, but we carry on working with the countries. We have also looked at some of the laws and try to do what we call, which is sometimes frustrating for me as an activist, but it is called the diplomatic engagement of the leaders. And we've been working with that as the Global Fund, but also ensuring that there's global solidarity, so mobilizing others that are outside Uganda. For instance, we work with a regional platform which is called the Global Fund Advocates Network in Africa. So we work with them, we support them to respond and support the different, so a cross-border collaboration advocacy kind of thing, and connecting the different countries. We are also working with those people that pray. Faith leaders. Faith leaders. We also work with faith leaders because some of these laws are influenced by faith community. So again, to sensitize, to ensure that we support the engagement. So there are lots of things that we're doing. There are mechanisms, there are reporting tools. We are also trying to leverage some of the diplomacy or diplomatic advocacy of the Global Fund to make sure that things are changing.
Applause, please. Yeah, thanks so much. I hope I didn't push too much for mentioning some of the countries. And I know that there's a lot of work going on, and most of this work is done behind curtain because you have to be diplomatic. But I'm an activist as well, so sometimes I would appreciate more undiplomatic voice than a diplomatic voice, but that's not how the world goes. So thanks so much for
I hear you.
For referring to the partners you are working with, the Global Fund Advocates Network and all the others. I hand over now to my colleague, Ben.
Thank you. So the last question from this round goes to Silvia. Silvia, one of the health priorities of the G7 Italian presidency is lifelong prevention for healthy and active aging. What are the proposals to ensure the right to person-centered healthcare across life, to prevent and reduce life-threatening and life-limiting conditions, and to improve end-of-life care, particularly in low and middle-income countries?
Thank you, Ben, for this very relevant question. According to the demographic data, G7 members are witnessing a constant aging of their population, which put the healthcare system under pressure all over the world. Healthy aging is also considered a global public health issue for developed and developing countries, and governments are required to adopt proper policies to address the challenges related to non-communicable diseases, promoting balanced and healthy dietary patterns, and discouraging individual behaviors as a sedentary lifestyle, smoking, and alcohol abuse. Improvement of lifestyles aimed at improving healthy life expectancy is a focal point of a person-centered care based on community services, with a view to investing in social and financial stability. With reference to lifelong prevention, Italy considers that countries need to implement programs starting from the prenatal phase, promoting comprehensive sexual and reproductive health rights for all, including maternal, newborn, child, and adolescent health, especially in vulnerable circumstances. Our presidency promotes also the consumption of locally grown food and the adoption of healthy diets to tackle obesity, chronic degenerative and oncological diseases, as well as malnutrition, with the aim of preserving biodiversity and sustainability, supporting communities' development and encouraging social equity. Moreover, vaccination screening campaigns need to be fostered in order to implement prevention habits and early diagnosis. In this perspective, investing in prevention is a tool to hinder social determinants of health and to guarantee the highest attainable level of well-being for everyone. Prevention is an investment, it is not a cost. And for a healthy aging, we need healthy youth. And lastly, we believe that investment in technological advancement as artificial intelligence and telemedicine will be crucial to improve the quality of healthcare and the provision of treatments, offering a highly relevant potential to increase equity in access to social and health services in remote places, while ensuring privacy and promoting interoperability. Now, going back to the main topic, as the population ages, not only health system will need to adapt and adjust in levels and types of service and care, we need the whole government and whole society response for older people, their families and communities, as also stated by the UN Decade of Healthy Aging. Fundamental shift will be required, not only in the action we take, but in how we think about age and aging. And we need to start thinking about these issues as soon as possible. Thank you.
Thanks so much. So we are now basically at the end of the two first sections of this event, and we come now to your questions. And we probably have 15 to 20 minutes time. And before I ask you to come up with your questions, you have to. We have online participants as well, so we will take 2 questions from the floor here and 2 questions from our online participants, and then there will hopefully be a second round of questions. I ask you, when you raise your question, please be short and concise. We do not allow a question that is longer than 45 seconds or 1 minute. So please don't breach. We want your question, okay? The other one is, please say your name and the country you come from, and the organization you work for. And probably tell us as well to whom you direct the questions. So please go ahead. I see Minnie, and then I see, let's take one woman and one man. Is this okay? So we start with the woman, Minnie, and then I don't know your name. You would be the second person. Thank you, and please be short and precise. Thank you.
Thank you so much, everybody. My name is Minnie Murthy. I'm a physician and a professor from New York. It's not a question, actually, it's a comment. It was a fabulous panel. I just want to say it's not only in low and mid-income countries. Even in the US, we have a lot of issues with access to drugs. Let me give you a very quick example before Peter kills me, that after COVID, the prices have gone up so much, especially in our older population. They are choosing between putting food or medication. So this is a global challenge, dear colleagues and friends, and we need to do something about it. And it's very dismal to see the pandemic preparedness fighting when we don't understand, or we don't want to understand, the urgency of it. So thank you so much. I think I'm within my limit. Thank you.
Yes, and there was no question involved, so thanks for that. Go ahead, please.
My name is John Paul Ngueya. I'm from Paris in France. So I'm working there with immigrant community from Sub-Saharan African and Caribbean. So in charge of HIV. So my question, looking like a response to the one that my colleague from New York just said, because no, we are like all of us here like advocate. Many of them online are advocate in their country. When are we thinking about the structuration? I don't know if they call it the architecture of people who are advocate for change. How can we put it in place? Yeah, so to have a team, like when you have a team, a soccer team on the stadium, you have the first, you have the defender, you have the goal. So when are we thinking to put it in place?
So this was about the architecture of community engagements. That was what I was. That was what I was understanding. You asked someone particular from us. Everyone. Okay. So we gather 2 more questions from our virtual participants, and then we answer the questions.
Great. Thanks so much, everyone. So from the online, we have one question coming in from Isatur Isur. And the question is to all panelists. How can investments in primary healthcare infrastructure and workforce development contribute to improving health outcomes in underserved communities? So thanks so much for that question. Over to you.
So who wants to respond first from our speakers? I see Mocha, and Mocha, I understood that you have to leave earlier, so please go ahead and respond. Thank you.
Okay, I was actually going to respond to as there was a question about what did we learn from Ebola and HIV and COVID for pandemic preparedness and prevention and preparedness, which again, it is a big part of my answer would be about investing in primary health care. And just to say, after Ebola, it was clear 3 important questions in my mind that we need. Once it was suddenly discovered when Ebola, I have to say that when some Europeans or Americans got infected by Ebola, suddenly the world discovered that we don't have a vaccine or a medicine. So that was one big question about investing in R&D for these diseases that are not, that we call neglected or tropical or whatever you want to call them. The second question is the importance of investing in healthcare. There's no escape from that. There's no free healthcare. There's no free primary healthcare. We have to address the fact that we need strong primary healthcare, and strong healthcare, including primary healthcare. And I actually, after Ebola, I wrote a paper called Never Again. Check it online. Was my name and Oxfam name. Where I put the health system as a chair. If you imagine a chair with 4 legs, so one leg is the infrastructure, primary health care, and also referral hospitals. One leg is health workers, and that's all workers from managers to doctors, nurses, labs, you name it, all of them. One is access to products. So, medicine, vaccines, protective equipment, all that. And the other one is health information system, which we forget. The way you sit on that chair, the sitting is how do you finance and deliver that system? And that will decide who sits on the chair, how to finance it. So investing in health system. The other thing that we learned again from Ebola is and COVID, the importance of creating trust. If the community and people trust the healthcare giver, whether it is a preventive message or a medicine or a vaccine, whatever you do with them, there has to be trust. Without the trust, the misinformation is incredible. And again, technology can play well and can play bad. So that's the other thing that we learn. Of course, what we learned from HIV and from COVID and from Ebola is the critical importance of community. And we talked about that earlier. On access, as I said before, we need to work around the value chain of access to medicine in order to avoid, to prevent, to prepare people. If any outbreak, it doesn't have to be a pandemic. It doesn't have to reach Europe to become, we have to do something about it. No, we do have disease in the community. And actually, that includes chronic diseases that are not pandemics. I personally believe that the world has a pandemic of cancer. It affects everybody, anybody, rich, poor, man, woman, young, old, anybody with a type of cancer is under the threat of a type of cancer. Now, do we have investment in prevention? Do we have investment in treatment? Do we have the medicine that happens, that exists? Does it reach people? It doesn't.
Thank you, Mocha.
I'll stop here and I'll say goodbye. Thank you very, very much.
Yeah, big applause for you, and thanks for being with us, even if virtual. Thank you.
Thanks. Bye.
So who wants to respond to the question on the architecture for community engagement? And I would add a second layer of question: who would support and not support finance that? I look deeply in the eyes of Linda and then Satyam. I'm sure you could say something about that. So please be brief, that we have time for a second round of questions.
I actually wanted to respond to the health systems one and primary health care because it is at the core of what the Global Fund is doing. Investing in HIV, TB, and malaria response has contributed in building stronger and resilient health systems. However, health systems that are only driven by government do not work until there's community systems as well, and ensuring that communities are part of that. So the primary care, it has to be influenced by communities because it's closer to the communities. And so when we talk about investing in resilient systems for health, we have to really also invest in community systems and ensuring that community-led monitoring and the data that comes from that is influencing the planning. I wanted to.
Thank you. But now back to the question, and applause for you. And so, Satyam, I ask you to respond to that. I'm sure you have
I also
some
wanted to
idea.
add something to what Linda just said.
Oh, you are doing what you want. We are we are sort of the moderators. You can do that, of course, but I please would like you to want the question from the audience, because
Just
it is
quickly.
unpolite not to answer that.
No, I mean, it's really interesting that we see the involvement of community perspective within health system, because health doesn't just happen within hospitals, right? It happens everywhere. And I think we really need to put emphasis on the recognition of work that's been done by peer educators, because many peer educators in African countries are currently facing threats to their life because of the work that they are doing, especially if peer educators from the LGBT community or peer educators from the sex workers community, or even if you're living with HIV, there's imminent threats to their life right now, and they are not able to do the job that they're supposed to do. So I think we should really emphasize on how we can protect these people and ensure that the work that they're doing is also recognized as being part of the health system. And what was the second question?
Yeah, so the question was, it was about the architecture for community engagement. What's needed there, if there's something missed, and how to finance that. Any idea on that, or is the architecture maybe already in place and just say it's already in place and that's it?
I think the architecture is here, but we just need to improve it in the sense that we really need to have the meaningful involvement of people, because the people are here, the people are sitting at the table, but how can we ensure that their voices are heard? This is the issue. And like I've been saying, even when the question was, how can we ensure that young people are participating? Young people are participating, communities are participating, but to what extent are we being heard? This is the question. To what extent are we influencing policies? This is what we need to invest on. So I think in terms of architecture, it's really like we need to come with frameworks and see how we can evaluate the impact that communities are making, and just see whether their voices are heard, and see what are the policies that are being influenced and how these people are really making that change, and not just sitting at the table just to tick that box and say they were present at that point in time and they were there, they gave their approval. Because no, we need to know what they gave their approval on. We need to know what they talked on. We need to know what they really want to do and sign off on that. I hope this answered the question.
Thank you. Thank you so much. We have a very, very small amount of time. We're going to take a couple of more questions in the room, and then we will take one, I think, from online. Okay, so within the room, yes?
Thank you, everyone, and thank you for this very meaningful conversation. I think we heard a lot, and I'll be brief, I promise. We heard a lot about social participation, and mostly like how can we have meaningful participation for civil society. And I put some information on the chat, but we are pursuing a resolution on social participation, on health and well-being, and UHC to be adopted at this WHA resolution. And so I think this is something we have to push for the adoption, but also for the implementation. And my question for you all today, specifically maybe for Linda and Carmen, but also Satyam, as you were like saying that sometimes our community are not heard and this resolution can change things, is how can we ensure that there is a follow-up after the adoption of the resolution, to have meaningful implementation in countries as an activist, but also maybe using some diplomatic ways and how we can collaborate together on this. Thank you.
Great. Thank you. And the lady here. Yeah. Yes.
Thank you very much. Just a few quick questions. I think we need to define some stuff. All right. So English is a borrowed language for me. You know, I'm not from the UK. I think that's where it comes from. Anyway, we use it to speak. I have a question for Carmen. That is, how do we continue the fight or continue keeping SRHR, especially the R, relevant in our countries where we're faced, we're facing a lot of resistance from communities, like close communities, neighbors, from our families who tell us something different, from the church, which tells us not to touch ourselves. You can't masturbate, you have to wait till you get married before you touch yourself. And schools, which aren't teaching comprehensive SRHR. What do you use how do we incorporate all of these barriers or these gatekeepers into a social participation dynamic platform? I wanted to ask Morgan a question, but of course she had to leave and Peter didn't give me a chance. So I'll ask it to anybody. What is your crystal ball saying about what's going to happen with the pandemic accord? What are we going to get? Are we going to get something that is really useful, or is this going to be TRIPS Agreement 2.0? That is to you. Last to Sislinda. The Global Fund is not going to be there for us forever. The Global Fund is already doing a few transitions, we know that. But at the same time, there's a theory of thought that the Global Fund has spoiled our country so much that we don't even have proper procurement, legislations or policies in our countries. So we don't even know where we're going to get our drugs in the next few years. What is your perspective around this? Because it's something that is at the top of a lot of our minds. Thank you.
Thank you. We're going to go to the online.
Great, thanks. So we do have one question from an online participant that I think feeds into a little bit as a precursor to what Lynette was asking, and that is, how do social determinants of health such as poverty, education, and gender equality contribute to global health inequities? So maybe that can be just maybe a precursor or an introduction to your responses to the questions that we've heard here today. And then we did have a question from Laura, but thank you very much for asking it in the room. That's wonderful. Thanks.
Thank you. So I think what we'll do, in the interest of time, we will let's give each of the panelists an opportunity to reflect on one or more of the questions that's been asked, but do so kind of in turn, starting with Shetiam, and then we go from my left to my right, and then after that, I think Robin is going to give a summary of the session. So if we ask each of the panelists to be less than a minute for the close up, thanks.
I try. So in terms of how can we ensure follow-up, to answer that question, I think us as communities, we also need to ensure that follow-up and not just wait for the follow-up to come to us, because it's really important that we hold people accountable to what they've been discussing in conference, in big meetings, saying that we are going to do stuff. We need to hold them accountable, and we are here to hold them accountable. So to answer your question, it's really interesting what you've been saying, and I think that we should ensure that that follow-up to be done. And in terms of the social determinants of health, I would say that, social determinants of health really do impact health of an individual. But we need to look at things in terms of how everything is interconnected. And when we were talking about the earlier question, we need to see that we need to ensure that we address things in a way that there is a continuity of care. And this is how we need to proceed from early childhood, from adolescent to adulthood. We need to ensure that the continuity stays within individual. And this is what's happening today. At one point, we break off from the health system. This is why we see all the challenges that we're seeing. So we need to ensure that we address all those barriers that we have so that we don't have that chain that breaks and that people are still connected to healthcare. Thank you.
Well, thank you for the opportunity to have this relevant conversation. I will try to give some transversal answer, bringing the perspective of the Italian Ministry of Health. Also, as I expressed in my previous intervention, I believe that investing in prevention should be at the heart of all health policies, including also social determinants of health. And primary care is in fact part of the prevention strategies at the very heart. And regarding the primary care organizations, it as also mentioned by the previous speakers, it should be at the heart in every country, and as we could support internationally and with international organizations support other countries, but anyway, it should be primary country responsibilities to ensure health rights for all and health equities. There, international funds can help, but anyway, it should be primarily also organized and managed by every single government, because this could be also be easier to involve communities, local communities, regional level as well. It can't be a top-down in fact, service, but it should be closer to as close to the citizen as possible. And I'll stop here because this would be otherwise a very long conversation. Thank you.
Thank you so much.
Well, I'm going to connect these questions to one of the previous ones. How can investment improve health services, direct health services and primary health services? Investment in social participation can ensure us to have the time to, because we activists, communities need the time to get involved in the process, to participate and to understand the processes of the health service so we can promote change, so we can improve and develop our community-led services. So when I think both questions have a connection. What do we do? Well, we fight. And how do we fight? We articulate as best as we can. We improve our community-led services. We work on each barriers on the ground. And then we work with our advocacy strategies to promote the very investment that we can on the different levels. And we promote that our voices are still heard and the commitments are not putting down. And well, we keep on going, asking for accountability on the process where we participated, and we keep on going, participating on as many spaces as we can. I don't know if I'm answering both questions as I'm feeling, but well, English is a borrowed language and jet lag is kicking in.
I think a couple of things for me, the resolutions that are going to come out of here, they need to be made consumable for civil society partners. So they need to be packaged in a way that civil society understand the resolution and therefore use them to advocate for change in their countries. And therefore, using some of the key platforms, your regional platform, your national platforms, to ensure that they are populated, they get the information is because information is power. And therefore, that would be my advice. We have many platforms, we can have a conversation there. The second piece around civil society engagement and the advocacy piece, we have seen a total onslaught on civil society and advocacy in many ways. There has been a political and a financial restriction of civil society to engage, to participate, to advocate. And therefore, we do need to organize and refocus and mobilize. But also, we need to call on to the donors that advocacy is not a voluntary work. It doesn't come cheap. And therefore, there has to be investment in advocacy. And that's something that we need, including us, to think about it and to also organize and mobilize around it. The last piece is around the countries, Lynette. the Global Fund has a team that is working, which is called the Health Financing Team, that is working with countries around transition and many other things. It's a long-term process. It's not a short thing that will just happen. And therefore, it's working with countries to look at their fiscal space and many other systems that need to be put in place so that they get to a point where we can say the country has transitioned out of the Global Fund. And as a result, we continue to call on the G7 countries to make sure that there are resources, they remain having health resources, health financing on top of their agenda, because the countries have not even recovered from the COVID-19 challenges around their economies. And therefore, readiness to transition out of the Global Fund does not make sense at this point in time. And that is why we continue to call for all the global leaders to continue supporting the Global Fund so that we can support the countries and keep the health financing on top of their agenda.
I think we hand over now the final remarks by Robin, and then we are done afterwards.
Yes. All right. Thanks, Peter. Thank you, everyone. I just wanted to follow up on something that beautiful Linda was saying around the onslaught against civil society. Honestly, that's a beautiful way of articulating it, because so I see it, we've been talking about the shrinking space of civil society for so long, but it's gotten to a point, and this is what I like to call it, civil society in shrink wrap. Because we are so constricted across the world in whatever we do, and we really need to fight back. So this was an incredible panel, and I just want to thank everybody for the incredible reflections and expertise in your lessons that you have shared with us, as well as the recommendations, the questions from the room, the questions from online, really very, very thoughtful. I think as Carmen and Linda so beautifully articulated, we, coming out of our sessions today, out of the summit, there's one thing that we really need to remember, and that is that we need to keep our voices loud, our voices proud, and we need coordinated action, right? Consumable information about what we've been doing here. That is something we really need to think about and work together on. And we also really need to understand the critical importance of diplomatic voice, diplomatic advocacy. We've heard from the Global Fund. We see it also within our government colleagues. We count on our Sherpas to also be diplomatic in their advocacy. We know that health is off the political agenda. We need to bring it back in because we know that it is a key driver to healthy, prosperous, resilient societies, communities, and households. And it is fundamental to the success of the SDG agenda, not just SDG 3, which is all health, but every other SDG of the 17 under that framework. We've heard today, and as I was recalling yesterday during our opening plenary, we've seen that we have an extensive and robust evidence base that shows us that when communities are at the center of policies, programming practice as active partners, as change agents, as innovators, that's when we really see transformative change come to life that brings better health outcomes, better system outcomes, greater efficiencies, social accountability that we've been talking about, and ultimately more prepared, just, and resilient societies. But to do this, we need the meaningful, equal, and inclusive engagement of all communities in civil society in decision-making at all levels, right? At policy, at programming, the levels of practice, at country, to global, with the keen mindfulness of the three principles that I love that Satyam was talking about: purpose, process, and power dynamics. So I just wanted to wrap up here and just say that as the Global Health Working Group, our work here today is not done. There is so much left to work on within this year and the years to come. So just wanted to share that we're going to continue our advocacy, our discussions, and our collaborative work, hopefully with everyone here who's with us in room and online, so that we can see the integration of our work, our recommendations into the final G7 and ministerial communiques, as well as policy coherence across some really important moments on the 2024 calendar. That includes the G7 summit, of course, the high-level political forum in July in New York on SDG 16, on the UN Summit for the Future, which is happening in September on the margins of the United Nations General Assembly, the G7 ministerial fall meetings, which include the health ministerial, as well as the development ministerial, and of course, the handover between the Italian presidency and the incoming Canadian presidency in 2025. So we have a lot of work cut out for us ahead, and it's really exciting to be working with you all. So thank you very much to our speakers. Thank you very much to Ben and Peter as our illustrious co-moderators, to everyone in the room, to everyone online. And before we say goodbye, we have a special announcement from Beatrice. So if I could ask Beatrice, please, to take the floor just quickly. And, oh, come on up, you can use the microphone. That's wonderful. And then I'll just say thank you and bon appetit.
Hello, everyone. Good morning. This is just a reminder. My name is Beatrice Mariottini. You probably saw me yesterday in the plenary where we launched the campaign Award Where. And I would just like to invite you to come by our stand. We are still in the same place, just outside the Red Room. And we are still looking for your contributions to our campaign that is focused on sexual and reproductive health and rights. And yes, that's it. And even if you already shared your thoughts and you want to add, we will be happy to have you by our stand. Thank you.
Thanks so much, Beatrice. Thank you, everyone. Thank you, everyone. Thank you, everyone. We will speak soon. Take care.